Okay, let's be honest. Does this just look like a total mess to you? For so many students, an ECG is this impossible code. It's like a chaotic scribble that holds these life-or-death secrets, and the fear of getting it wrong, it's real. But what if I told you that you've been thinking about it all wrong? That it's not about memorizing a million patterns?
What if it's actually a story, and all you need is the key to unlock it? Well, in the next few minutes, I'm going to give you that key. I'm going to walk you through a 7-step method that turns this chaos into a clear, confident diagnosis. And I mean every single time.
See, reading an ECG isn't some kind of magic trick. It's all about having a system, a reliable method that you can fall back on, especially when the pressure is on.
And here it is. This is our roadmap. Think of it as your guide from chaos to absolute clarity. It's 7 simple steps, and here's the secret. You do them in the same order every time. That way you'll never miss anything critical. So let's start our journey with the most basic question of all. Just how fast is that heart beating? All right, step 1, the rate. It's all about speed. Is the heart racing? Is it crawling along? Or is it just right? This is our very first clue in this detective story.
You know, figuring out the rate can be surprisingly easy. We've got 2 great ways to do it. For a really quick and dirty estimate, maybe in an emergency, you can use the R-wave method. Just count the number of those big spikes, the R waves, on the rhythm strip and multiply by 6. Boom, you've got your rate. Now, if you want to be a bit more precise and the rhythm is regular, the 300 method is your best friend. Just count the number of big boxes between 2 beats and divide 300 by that number. See? Simple. Either way, you get the answer you need. Is it normal, too fast, or too slow?
Okay, so we've got the speed down. Now, what's next? The pattern. Is this heart beating like a steady drum, or is it just all over the place? This is where we dig into the rhythm. And I want you to think about it like this. A normal, healthy sinus rhythm, that's like a perfectly disciplined army. You've got the sinus node, the commander, giving a regular order, beat, and all the heart cells just fall in line, contracting in perfect time. But then you have something like atrial fibrillation, and that, well, that's a panic crowd. The atria are just quivering, chaotically firing off signals left and right, bombarding the AV node, and the result, a rhythm that's completely, irregularly irregular. So what about when the heart is too slow? A lot of the time, the problem is a communication breakdown. The atria and the ventricles just aren't talking to each other properly. And to make this super easy to remember, we're going to use an analogy I think you'll love. Think of it as a relationship story. The P wave, that's you making a plan for a date. And the QRS complex, that's your partner actually showing up. So first up, we have a first-degree block. This is the chronic latecomer. They're always late. You'll see that the PR interval is a little too long, but hey, at least they always show up. Every P wave is followed by a QRS. Then there's second-degree Mobitz 1. Let's call this the growing distance. Your partner gets later and later and later until finally they just don't show up for a date. You'll see the PR interval get progressively longer and then a dropped beat. Now Mobitz 2 is different. This is the unreliable partner. They're usually on time, the PR interval is constant, but then completely out of the blue, they just stand you up. A P wave with no QRS. This one is way more dangerous because it can suddenly turn into a complete block, and that brings us to third-degree block. The divorce. It's over. The P waves and the QRS complexes have zero relationship. They are completely doing their own thing, and that's why this patient is almost definitely going to need a pacemaker. All right, next up, we need to figure out the heart's electrical orientation. So for step 3, we're finding the axis. This basically gives us a bird's-eye view of which way the electricity is flowing overall.
And please, forget all those complex calculations you might have seen. The thumbs-up technique is pretty much foolproof. Seriously, you just look at the main spike, the QRS in lead I and lead AVF. Are they both pointing up? That's 2 thumbs up. Your axis is normal. Are your thumbs pointing away from each other? That's left axis deviation. And if they're pointing toward each other, right axis deviation. It really is that simple.
Okay, quick check-in. We have rate, we have rhythm, and we have axis. Now for step 4, we're going deeper. We're going to look at the timing of the heart's electrical highways. Because let me tell you, delays or dangerous shortcuts here can be the very first sign of some really serious trouble.
And there are 2 intervals you absolutely have to pay attention to. First, if you see a short PR interval and it has this little slurred upstroke, we call that a delta wave. That screams Wolff-Parkinson-White syndrome. It's a dangerous electrical shortcut in the heart that can set off some life-threatening arrhythmias. On the flip side, a long QT interval is a huge red flag. It means the ventricles are taking way too long to reset,
which puts the patient at risk for a really scary fatal arrhythmia called torsades de pointes. So now we're going to start looking at the actual shape of the waves. Steps 5 and 6 are all about morphology, and the shape can tell us a ton, like if parts of the heart muscle have gotten too big, or if the electrical signal is having to take a detour.
Let's kick things off with the P wave. Take a close look. Does it look kind of like two camel humps? That's a classic sign that the left atrium is enlarged. Or maybe it's super tall and pointy, like a Himalayan peak. That points to the right atrium being enlarged. These little visual cues tell a huge story about chronic strain on the atria.
Okay, what about the ventricles? Well, if the heart muscle is constantly overworked, maybe from years of high blood pressure, it does what any muscle does. It gets bigger, it gets thicker. And on the ECG, that shows up as huge voltage. I'm talking about skyscrapers on your screen. So if you see really deep S waves in lead V1 and super tall R waves in V5 or V6, you should immediately be thinking about left ventricular hypertrophy.
Sometimes the electrical signal gets blocked on its normal path and has to take a detour. We call these bundle branch blocks, and luckily there are some super simple patterns to help us spot them. For a right bundle branch block, look in lead V1 for an RS-R' pattern. It literally looks like a pair of rabbit ears. And for a left bundle branch block, just remember the name William. You'll see a W shape in lead V1 and an M shape in lead V6. William. See? Easy.
Okay, everyone, we've made it to the final step, and honestly, this is the most critical one of all. Step 7 is where we hunt for evidence of a heart in acute distress. We're looking for signs that the heart muscle is starved for oxygen, or even worse, that it's actively dying.
First, let's talk about ischemia. That's the medical term for when the heart muscle is starved for oxygen. I want you to imagine the heart is trying to do its job, but it's carrying a really heavy backpack. What happens? It starts to sag under the weight, and that's what you see on the ECG. The ST segment sags, or depresses. It's a clear sign of strain and struggle.
But this is the one you can never miss. Infarction. This means heart muscle is actively dying. Usually it's because a coronary artery is completely blocked. And the hallmark sign on the ECG is ST segment elevation. When you see this, it is an absolute emergency. Everything stops. Because you have to remember, time is muscle.
Now this is so important. Not all ST elevation means a heart attack, and being able to tell the difference can literally save a life. It all comes down to the shape. If you see concave elevation, it kind of looks like a smiley face. That's often benign. But if you see convex elevation, which looks like a tombstone, well, that is highly specific for a heart attack. It is a sign of extreme danger.
And this is the real power of a 12-lead ECG. It doesn't just scream, hey, there's a heart attack. It acts like a map, telling us exactly where the problem is. So for example, if you see that tombstone ST elevation in leads I, 3, and AVF, you know with confidence that it's the inferior wall of the heart that's in trouble. That points you right to a probable blockage in the right coronary artery. And knowing that location is absolutely crucial for guiding treatment.
So let's just run through our checklist one more time, shall we? This is your foolproof system. Number 1, rate. 2, rhythm. 3, axis. 4, intervals. 5 and 6, the morphology, looking at the P wave and QRS. And finally, the big one, number 7, checking the ST segment and T wave for any signs of ischemia or infarction.
Okay, let's put this system to the test. Let's look at this ECG. Step 1, the rate, looks to be about 75, so that's normal. Step 2, the rhythm, it's nice and regular. Step 3, the axis, 2 thumbs up, it's normal. Step 4, intervals, they look fine. 5 and 6, morphology, nothing really jumps out. But then, we get to step 7. And what do we see in leads I, 3, and AVF? There it is, clear as day. That is convex, tombstone ST elevation. And just like that, in a matter of moments, we've gone from a bunch of confusing squiggles to a confident diagnosis, acute inferior ST elevation myocardial infarction. That is the power of having a system.
You see, when you apply this 7-step method every single time, you build this powerful habit. And that habit is what replaces fear with confidence. You'll be able to pick up any ECG and read the heart's electrical story clearly and accurately. So now I have a question for you. Which of these 7 steps do you still find the most challenging? Or maybe, which one of the analogies we used today was the most helpful for you? Go ahead and share your thoughts in the comments below. I'd love to hear from you.